It's my great pleasure to be here at this conference as well, and I first want to thank the organizers for this outstanding conference. It's really a pleasure to be here and to speak about nephroblastoma now, which is belonging to the WAGR syndrome. Not every patient with a WAGR will have a nephroblastoma or Wilms tumor. And before I go into the WAGR syndrome itself, I just want to give you a small overview. As you may know, nephroblastoma or Wilms tumor is the most common kidney tumor in childhood. Nevertheless, it is a rare disease. And you see also that about 10% of all the kidney tumors are bilateral kidney tumors or bilateral nephroblastoma. And one part of that is nephroblastomatosis of nephrogenic rest, which is also playing a role in WAGR syndrome. And you may also note that the outcome of patients with nephroblastoma did increase steadily. And the main impact were the prospective clinical trials, where randomized studies in North America, primarily the National Wilms Tumor Study, and then nowadays the COG, Children's Oncology Group, and in Europe, the PSYOP studies were done. And you see from the PSYOP studies that we did collect many patients over the years in different clinical studies, and we now have more than 10,000 patients having had nephroblastoma, and only a small number of these patients having also a WAGR syndrome. And it was a collection, again, international collection in many countries. And in the ongoing study we have now, we are having and addressing more than 50 countries, not only in Europe, but also in South America, in Russia, in China, in Japan, Australia, and other countries as well. And this will give us more insight into nephroblastoma. In contrast to the COG in North America, we start always with preoperative chemotherapy. And I show you here the picture of a kidney tumor on the left side, where you see two lesions in the left kidney at the time of diagnosis. And after 4 weeks only of chemotherapy with vincristine and actinomycin D, you see how the tumor is shrinking, and that makes the operation much easier, and even you can do nephron-sparing surgery in part of these kidneys. And going to the metastatic diseases, you see how the lung metastasis may vanish after chemotherapy. And this was one of the reasons why this downstaging was used in PSYOP from the beginning, because we did see that the local stage distribution did increase, the rupture rate did decrease over time, and that followed after surgery by less treatment and less toxic treatment. And this is very important for the late effects of these kids. And you can see here also the number of patients that were irradiated over the different studies, and you see the rate is now around only 20%. And this irradiation has a lot of side effects. And these studies will get more and more complicated, as you can see here. And I don't want to go into details, but I just want to show you that all these studies have randomized questions, not only to make the outcome better, but also to reduce the outcome in these patients. For example, in the last study of 2001, we asked if patients in the intermediate risk group do need anthracyclines. And anthracyclines have the long-lasting effects of cardiomyopathy, and we could show that there is no anthracyclines needed for these patients. But we have also problems. Here you see the outcome of patients with nephroblastoma according to the local stage, and the overall stage as stage 4 is the stage with metastatic disease. and you see the different histological risk groups, low risk, intermediate risk, and high risk. And I want to show you that especially in the low risk group, there's a very high survival rate, and in the high risk group, we still have problems. And if you look for metastatic disease and high risk, which is especially anaplasia, you have only 36% of survival rates, which is very, very poor. And this is also important when you see going to the WAGR syndrome later on. We now know a lot of somatic mutations in Wilms tumor, and this is listed here. This is starting with the WT1 mutations or deletion, and it's going up to P53 deletions, but there are still 25% of known abnormalities. And we also can look what is the relation to the phenotype of the tumor, and we see that WT1 is often associated with a stromal subtype, and there's a lot of other subtypes like the epithelial with TRIM28 and others, and the P53 with the anaplasia or plastemal subtype. And these tumors have a poor outcome. So we also know that about 6 to 19% of patients, and it's depending on the registry, with Wilms tumor have a cancer predisposition syndrome or are associated with malformations. These are genitourinary malformations, WT1 involved syndromes. Here's the WAGR spectrum, and I use the name spectrum here as well because it's not only a syndrome. And there's the Dennis-Trash syndrome with point mutations in the WT1. And there are predisposition syndromes dealing with the hemihypertrophy, which may be an isolated hemihypertrophy or the Beckwith-Wiedemann syndrome. And going now specifically to the WAGR syndrome and nephroblastoma, there's an actual paper written last year by Jana Holl from the PMZ in Utrecht in the Netherlands from our SIOP group, and this is a 30-year SIOP RTSG experience looking into WAGR syndrome and Wilms tumor or nephroblastoma. And what you can see is that over this period of years, we only were able to find 43 WAGR patients where the diagnosis was confirmed. Whereas in the whole population, you have seen there were more than 10,000 patients with nephroblastoma enrolled. So this is really a rare disease, nephroblastoma or nephroblastomatosis in WAGR patients. And as also shown, again, showing that it is a spectrum, you have many other findings, not only the ocular findings, but you have those findings that were just mentioned in a very nice talk, and we need to be aware of that, and this is also highlighted in this paper, which is really, really very good. And if you are looking for the outcome of these patients, you see the outcome of these patients is also between 80 and 90%, so which is not bad. And what you can also see, there's still some decrease in the curve after more than 5 years. So afterwards, it seems to be stable. There's another analysis that was done in the German nephroblastoma trial, and we are looking, and this is the summary of what was written in that paper about Wilms tumor and WAGR. It has a high rate of bilateral diseases, which is 37%. So this is a predisposition syndrome, and it might affect both kidneys. And very important, there were no anaplastic tumors found. These anaplasia are those tumors with a poor outcome. No metastatic disease, which has also in the combination with anaplasia a poor outcome. And often the mortality was due to non-tumor related diseases or causes, and this is the reason why you need always to look in those patients not only for the nephroblastoma, but you need many other specialists. And the kidney function, for example, needs to be followed over time. There must be a surveillance at least for 5 years. I think personally it must go longer, but there is a discussion in the community with nephroblastoma doctors who think 5 years is enough, but I don't think so. And we believe that the preoperative chemotherapy is relevant because then we have a higher rate of nephron sparing surgery because the tumor will decrease. And the management and treatment must always be done by a multidisciplinary team. So now I go to another publication which was done only by German patients, where we try to characterize nephroblastoma, nephroblastomatosis in underlying malformations, not only in WAGR, but to show you this paper shows you also the difference between WAGR and other predisposition syndromes, which I believe is also relevant to understand the WAGR spectrum. So if you see the frequency of cancer predisposition syndromes, CPS, and malformations, then there are 5 malformations that are most frequently in nephroblastoma. This is WAGR. These are the genitourinary malformations, the Dennis-Thresh syndrome, the Beckwith-Wiedemann syndrome, and the isolated hemihypertrophy, which causes most of these cancer predisposition syndromes in nephroblastoma. And you see here also from a collection of nearly 3,000 Wilms tumor patients, only 20 did show up with a Wilms tumor. And if you see that these 20 patients are also about 30 years in the past, and you compare to the 40 patients from whole Europe, there must be some patients missed, even if it is a WAGR syndrome. So what I think that these registries are very important. And you see that is a rate of under 1% of nephroblastoma who has a WAGR syndrome. And you see on the other hand that 30% of these, I think this is an, oh yeah. And you see also 30% of these patients with WAGR syndrome have a bilateral disease. So this is really a difference because all patients with Wilms tumor here showed only 8.6% of bilateral diseases. And what is also important is the question of screening. Many patients with WAGR syndrome were diagnosed before the nephroblastoma did occur. But there are also patients who were diagnosed after nephroblastoma was diagnosed. And you see here that only 8 patients, sorry, I'm too stupid. Only 8 patients of the 20 patients did underwent a screening by ultrasound. All the others not. And I think that needs to be improved. If you compare that to the other predisposition syndromes, there's not a big difference. You see here the percentage is even smaller in genitourinary malformations, and it is a little bit higher, but it's nearly the same in the Beckwith-Wiedemann syndrome. And I tell you why this is so important. Here, look, another thing which is important is the early age of patients with WAGR syndrome. You see here the age of patients with WAGR syndrome, or the WAGR Wilms tumor with syndrome, is lower than for all the other nephroblastoma or Wilms tumors. And if you have here the WAGR syndrome, you see it is very low. The only predisposition syndrome that has even a lower age in the median is the Dennis-Stresch syndrome, but this is also a WT1 abnormality. And all the others are somehow older when they are diagnosed. So early age is a very important issue, and one of the reasons for that it is very important is then also if you look into the mean tumor volume at diagnosis. And you can see here the mean volume at diagnosis in patients without a cancer predisposition syndrome is nearly 500 milliliters, which is a huge tumor. Think about the median age is between 2 and 3 years, and there's a tumor of 500 milliliters in the abdomen. And patients with predisposition syndromes have a lower tumor volume at the time of diagnosis. And now see in WAGR patients, it's just 100 milliliters, so much smaller than the normal Wilms tumor here. And this is important, and I show you a figure of outcome, why the volume is important. And you see here all the other syndromes have higher tumor volumes. And again, the volume after preoperative chemotherapy is shrinking in all patients in the median. The volume here is then not as much shrinkage as in others. Here's half of the tumor volume. This is not half of the tumor volume. This is depending on the histology being behind. You see here half, and this is only 20% around. And you see also that there is in the Dennis-Stresch syndrome also WT1 mutation. There is no shrinkage at all. And this is depending because stromal subtype of nephroblastoma do not respond very good to the chemotherapy, and the stromal subtype is really associated with WT1 mutations. And if you do surveillance for these patients and look into the tumor volume, you see the tumor volume is still going down. So surveillance is really important, and this is independent if this is a WAGR or if this is a Beckwith-Wiedemann syndrome. Oh, sorry. No. I made it in the wrong direction. And if you do the screening method, you can also look here in the different tumor volumes in the different diseases, and you see here how small the tumor in WAGR syndrome is if you do the screening. But also in the other CBS, you see a really large difference between those patients with the syndrome without a screening, without an ultrasound of the abdomen, and then you see what the ultrasound makes. And also you can look at the frequency of metastatic disease. And you see we have only one child who had really a metastatic disease out of the 20. And 19 had a non-metastatic disease in nephroblastoma. And this is smaller numbers than in the others. And so WAGR and metastatic disease is very unusual, and this was a patient that was not screened, and this was a patient that had the largest tumor of all the WAGR patients. So that might also be a reason to screen and to find patients early that develop a nephroblastoma. One other point I want to remember or show you is the question of nephroblastomatosis in cancer predisposition syndromes. Nephroblastomatosis as a predisposition to Wilms tumor, and I have here divided into isolated nephroblastomatosis or nephrogenic RES, Wilms tumor with nephroblastomatosis or nephrogenic RES, and those patients who have only Wilms tumor. And if you look into patients here of WAGR, you see that 35% of them has isolated nephroblastomatosis. There are 10% who have in combination with Wilms tumors, and only half of the patients have no nephrogenic rest or nephroblastomatosis. And the treatment of nephroblastomatosis, nephrogenic rest, is much more difficult than for nephroblastoma. And if you compare that to the other cancer predisposition syndromes, you see also in other cancer predisposition syndromes a high rate of isolated nephrogenic rest or nephroblastoma, but it's the highest in the WAGR patients. And you see that this might have an impact on the outcome. And if you look into the histology, and I put here the stromal subtype, because this is the subtype that do not good respond, but we didn't find any patient in these 20 with the stromal subtype in a WAGR syndrome. And we only found one with a plastemal subtype, but again, no one with anaplasia. So that shows that most of these patients had other histological subtypes. And you see here, for example, in DDS, which is a WT1 mutation, there are 9 patients who have a stromal subtype, which is the highest rate in all of these patients, and their tumor reduction, I've shown you before, was 0. The outcome now. You see here the group of all patients with no syndrome at the time of diagnosis, then those with a syndrome, and here are the WAGR patients. And you see here of these 20 patients, there were 2 deaths occurring in these patients. And these deaths were not only related to the tumor itself. And you see what is really interesting is also the question of, and you can see here, the event-free survival after 10 years. It's still going down. After 5 years is 87%, after 2 years also 87%, but it's going down up to 10 years to 77%, whereas the overall survival remains the same. So we can do something for that, and if you compare that with the other groups like Beckwith-Wiedemann syndrome, it is even going more down, and this is always related to the nephrogenic rest or nephroplastomatosis, because this is really an issue where late relapses or late effects can occur, and that makes the outcome not as good as for the other patients. But still, if you look only to tumor volume, you see why screening is so important. The smaller the tumor volume at diagnosis is, and I've put here the 500 milliliters, because the 500 milliliters is around the median volume of these tumors at diagnosis, and you see, depending on the tumor volume, the outcome is completely different. So screening is very important, and preoperative treatment is important, because if you can go down with the tumor volume by preoperative treatment, then the outcome will getting better. Doing a multivariate analysis for outcome in all these patients with cancer predisposition syndromes, and you have the nephroplastomatosis. The nephroplastomatosis is a very important issue, as it is for the bilaterality. And you can see, if you are looking into into the bilaterality, this has the highest impact on relapse in these CPS patients, where it is not the case in those other patients. And this is also for the WAGR syndrome patients, but the number is so small that there is no statistically significant difference. So if you summarize this, you see that in WAGR patients the prevalence is very low, under 1% of all patients with a nephroblastoma. The median age is low, lower than for the normal nephroplastomatosis. The gender distribution is the same as for nephroblastoma. The characteristic histology is nephroplastomatosis and nephrogenic rest, where I believe we need to improve the treatment for nephrogenic rest and nephroplastomatosis. There's a high percentage of bilaterality, a small tumor volume at the time of diagnosis, the smallest after screening, and the tumor is not shrinking as much as for other conditions, but better as for the DDS patients. The 5-year event-free survival is around 87%, but I have shown it's going down, and this is something we need to address, and this is mainly related to the nephrogenic rests. And what we all want to achieve is such a situation where you have, at the time of diagnosis, these bilateral tumors with nephrogenic rests here, and the tumor in the other kidney, and this is 10 years after treatment, successful for these patients with the bilateral tumor. And I think that is what I want to say. What I want to remind again is the question that you have always additional findings in WAGR syndrome. As said before, I don't want to go into detail here, but what is also important is the internationalization of the physicians, of patients, everyone. You see here, you need to do that for internationalization, to get more patients, to get all the patients into your cohort. And summarizing for the CPS, the cancer predisposition syndromes, you can divide these patients in two groups, where you have a nephroblastoma where you don't know that there is a CPS behind, and you may have a known CBS. And if you have an unknown CBS, please think if it is a younger patient with age, if the patient has malformations, if the patient has a bilateral disease or nephroplastomatosis, go to genetic counseling. This is really important. And the second point here is, if you know there is a CBS, and despite of non-metastatic tumors and small size, the outcome is sometimes not beneficial. And this is something you need to take into consideration. And this is one of the home take messages as it is. Go to internationalization and speak to the parent groups and do it together with them. And at that point, I want to thank all the clinician scientists who were enrolled in these studies, but also the patients and parents and the funding organizations to make this work possible. Thank you.